Welcome to the deep dive. Today, we're tackling a really important topic in pediatrics, juvenile idiopathic arthritis, or JIA.
Yeah, it's one of those conditions that, can seem quite complex for families and even for trainees.
Exactly. And understanding childhood illnesses like this can sometimes feel a bit overwhelming. So our mission here is to cut through that complexity.
Make it high yield, basically.
Precisely. We want to give you a clear, really usable understanding of JIA. We're basing this on the Juvenile Idiopathic Arthritis Overview resource, pulling out the key stuff for quick learning, especially useful if you're revising for something like the MSRA.
Sounds good. Where should we start?
Yeah.
Definition.
Let's do it. So fundamentally, what is JIA?
Okay, so JIA is basically a chronic, long-term autoimmune disorder. That means the body's immune system mistakenly starts attacking the joints.
In children specifically?
Yes, specifically in children under 16. And the key diagnostic point is that the joint inflammation, the arthritis, has to be present for at least 6 weeks, and it must have started before their 16th birthday.
6 weeks is quite specific. It rules out just a temporary thing then.
Exactly. It points towards something chronic. Think of it as the immune system just getting confused and causing ongoing inflammation where it shouldn't.
Now, the overview mentions a few different names. Still's disease, juvenile chronic arthritis. Why is it helpful to know those?
Ah, yes. That's a good point. You might come across those older terms: Still's disease, juvenile arthritis, juvenile chronic arthritis, even juvenile rheumatoid arthritis.
Right.
Knowing they all essentially refer to the same group of conditions, JIA, just helps avoid confusion if you're reading different texts or older papers. It streamlines things.
Makes sense. And it's not just one single condition, is it? The overview mentions subtypes.
That's right. JIA is actually an umbrella term for 7 distinct subtypes. They're classified based on how the condition presents in the first 6 months, using what are called the ILR criteria.
ILR criteria.
Yeah, the International League of Associations for Rheumatology. It's just the standard classification system.
And those 7 subtypes are? Can you give us a quick list?
Sure. There's oligoarticular, then polyarticular RF negative, polyarticular RF positive,
Okay.
systemic onset JIA, juvenile psoriatic arthritis, enthesitis-related arthritis, and finally, undifferentiated arthritis.
Wow. Okay. Quite a few variations there. We'll definitely need to unpack those later.
We will. Each has its own features.
So moving on from the what about the why? What actually causes JIA? Do we know?
Well, that's the million-dollar question, really.
Yeah.
The exact cause is still unknown. Idiopathic literally means of unknown cause.
Ah, right. Idiopathic.
But the general thinking is that it's likely an interplay between a child's genetic predisposition, meaning they have certain genes that makes them more susceptible,
Okay.
and then some kind of environmental trigger. Maybe an infection, though we haven't pinned down specific ones consistently. These factors together seem to kind of, flip a switch and activate the immune system inappropriately against the joints.
So it's complex, not like catching cold. Are there specific things that make a child more likely to get JIA? Risk factors.
Yes, there are some known risk factors. Having a family history of autoimmune diseases, not necessarily JIA itself, but things like rheumatoid arthritis or lupus in the family, can increase the risk slightly.
Okay.
We also know specific genetic markers, like certain HLA types, are involved, but we don't need to get into the specifics of those right now. And as I mentioned, those environmental factors are strongly suspected to play a role, even if they're hard to identify individually.
Got it. So genes, environment, family history, it all mixes together. And pathologically, inside the joint, what's going wrong?
The core problem is that misdirected immune system activation. This leads to chronic, ongoing inflammation of the synovial membrane.
That's the lining of the joint.
Exactly, the synovium. And this chronic inflammation causes the joint to swell up, become painful, stiff, and warm. And critically, over time, this inflammation can actually damage the cartilage and bone within the joint.
Which leads to long-term problems, I imagine.
Precisely. That's why early diagnosis and treatment are so crucial to stop that damage.
It makes sense. But, joint pain in kids, lots of things can cause that. How do doctors make sure it is JIA and not something else? What's the differential diagnosis like?
You're absolutely right. The differential is broad. It's really important to rule out other conditions. You need to think about other types of arthritis, like rheumatoid or psoriatic, although they often look a bit different in kids.
Okay.
Infections are a major thing to rule out septic arthritis, which is a bacterial infection inside the joint. Is a true emergency. Also, osteomyelitis, a bone infection near the joint.
Right. Infections are key.
Then you've got reactive arthritis, which can happen after an infection elsewhere in the body. Simple trauma or injury, mechanical pain from overuse, various pain syndromes, even things like inflammatory bowel disease, which can have joint symptoms, or sadly, sometimes malignancy like leukemia can present with bone pain, and other autoimmune conditions like lupus.
Wow, that's quite a list. Septic arthritis, osteomyelitis, reactive arthritis, trauma, IBD, malignancy, lupus. It really underscores why a thorough workup is needed.
Definitely, it's not always straightforward.
So how common is JIA? What does the epidemiology look like, say, here in the UK?
It's actually the most common chronic rheumatic disease in UK children. So while it's not super common compared to, say, asthma, it's significant within rheumatology.
And the numbers?
The estimated incidence new cases per year is roughly 1 in 1,000 children, maybe slightly less depending on the study. The overall prevalence, so the total number living with it, is maybe around 1 to 2 per 1,000 children. Another way to look at incidence is about 1 new case per 10,000 children per year.
Okay. And any difference between boys and girls?
Yes, overall, it's more common in females, but that does vary quite a bit depending on the specific subtype. Some subtypes are actually more common in boys.
Interesting. And it happens worldwide?
It does, yes. It occurs globally, although there are some geographical variations in prevalence and the distribution of subtypes.
Right. So let's get down to the clinical picture. If you're a parent or a young person or a clinician seeing a child, what are the classic symptoms and signs that should make you think, could this be JIA?
Good question. From the patient's perspective, the common symptoms they'll report are things like joint pain, obviously, visible joint swelling, stiffness, especially noticeable in the morning or after sitting still for a while.
That morning stiffness again.
Yes. Also, limited range of motion, they just can't move the joint as fully as usual. Sometimes the joint might feel warm to the touch or look red. Fatigue is another really common non-specific symptom. And then depending on the type, you might get fever, a rash, or even eye inflammation, uveitis.
And what would a doctor look for on examination? What are the signs?
Well, that morning stiffness that gets better with movement is a huge clue. We call that gelling. They'll look for objective limitation of movement in the joints due to pain or swelling. A limp is common if a leg joint is involved.
Makes sense.
They might find enthesitis, that's tenderness or swelling, where tendons or ligaments attach to bone like at the heel. Fever can be a sign, particularly that specific spiking quotidian fever in systemic JIA. A characteristic salmon-colored fleeting rash can also occur, sometimes with systemic JIA. And a red eye could signal uveitis, which needs urgent attention from an eye specialist.
You mentioned diagnosis hinges a lot on these clinical features. Can we recap the really key pointers linking back to risk factors, maybe? What combination shouts JIA?
Sure. So you consider the risk factors, often female gender, maybe specific HLA types if known, a family history of autoimmunity. But the clinical picture is paramount. It's persistent joint pain, usually with that morning stiffness improving with activity. Objective joint swelling is key.
Not just pain, but actual swelling.
Exactly. Limited joint movement, maybe a limp, enthesitis. Then the systemic features that present. The fever pattern, that specific salmon rash, which sometimes shows Koebner's phenomenon, meaning it flares up after scratching the skin. And always thinking about uveitis, the potential for eye inflammation.
That's a great summary. Okay, let's dive into those 7 subtypes now. You listed them earlier. Let's break down what makes each one distinct. Start with oligoarticular.
Right, oligoarticular JIA. Remember, oligo means few. So this type affects 1 to 4 joints within the first 6 months of the disease. It's the most common subtype overall.
1 to 4 joints?
Yep. Often these kids test positive for ANA, the antinuclear antibody, which is important because ANA positivity is linked to a higher risk of uveitis.
Oh, okay. Important link.
And the joints most commonly hit are often the large joints, especially the knee and sometimes the ankle.
Okay. Memory tip. Oligo, think O for 1 or few joints, often knee, ankle, ANA positive common.
Good one.
Next up, polyarticular JIA. You said there were 2 types.
That's right. Polyarticular means many joints.
Yeah.
So 5 or more joints affected in the first 6 months. First, there's the RF negative, meaning they test negative for rheumatoid factor, that antibody we sometimes see in adult rheumatoid arthritis. This RF negative polyarticular type is quite common. It often peaks in toddlers, preschoolers, and then again in pre-adolescents.
Yeah.
The joint involvement tends to be asymmetrical, maybe the right wrist and left knee, for example. There's also a risk of uveitis here, and it can affect both large and small joints.
Right. Memory tip. Poly R5, many joints, but RF negative. Asymmetrical can affect big and small joints.
Perfect.
And the other polyarticular type.
That's a polyarticular RF positive. Again, 5 or more joints in the first 6 months, but this time they test positive for rheumatoid factor.
Ah, so the RF marker is the key difference.
Exactly. This type often looks more like adult rheumatoid arthritis. It typically involves symmetrical inflammation, affecting the same small joints on both sides, especially the hands and wrists. These children might develop rheumatoid nodules, those lumps under the skin, and sometimes have more systemic symptoms.
Okay, so RF positive is more symmetrical, small joints, kind of like adult RA. Memory tip. Polymany joints, R3, and RF positive marker. Think RA like symmetrical, small joints.
You've got it.
Okay, next subtype, systemic JIA. That sounded quite different.
It is. Systemic JIA involves arthritis, yes, but the defining feature is a characteristic fever lasting at least 2 weeks. It has to be a daily fever, typically spiking high once a day, usually over 39 degrees C, and then returning to normal or below normal, 37 degrees C. That's the quotidian pattern.
Very specific fever pattern.
Very. And it's often accompanied by other systemic features, that transient salmon pink rash, swollen lymph nodes, an enlarged liver or spleen, hepatosplenomegaly, and sometimes inflammation of the lining around the heart or lungs, which is called serositis.
So the whole body is involved.
Yeah.
Memory tip. Systemic affects the whole system with that classic daily fever and organ involvement.
Precisely.
What about juvenile psoriatic arthritis? Does it always involve the skin condition?
Not necessarily the patient having psoriasis themselves, although often they do. The definition is arthritis plus either psoriasis in the child or a family history of psoriasis in a close relative, or specific signs like nail pitting or dactylitis, which is sausage-like swelling of a whole finger or toe.
Ah, okay. So arthritis plus psoriasis or related signs.
Exactly. The arthritis itself is often asymmetrical. Memory tip. Look for the skin link. Psoriatic means psoriasis or related features.
Got it. Next is enthesitis-related JIA. What's the key here?
Enthesitis-related JIA is defined by having either arthritis or enthesitis, that inflammation where tendons attached to bone, plus some other specific criteria, like things like sacroiliac joint tenderness, inflammatory back pain, testing positive for HLA-B27, onset after age 6, being male, more common in boys, or having acute uveitis. It often affects the lower limb joints and the spine later on.
Okay, so enthesitis is key, often lower limbs, often boys, often HLA-B27 positive. Memory tip. Think E for enthesitis, M for males, HLA-B27.
As mnemonic.
And the last one was undifferentiated arthritis.
Yes. That's basically the category for children with chronic arthritis that doesn't neatly fit into any of the other 6 categories, or fits into more than one.
The doesn't fit elsewhere box. Memory tip. It's what's left over.
Pretty much.
Okay, that clarifies the subtypes really well. So with all these variations, how do doctors investigate? You said it's mainly clinical, but what tests help confirm things or classify the subtype?
Yeah, it's crucial to remember there's no single diagnostic test for JIA itself. It remains a clinical diagnosis of exclusion, meaning you rule other things out. But investigations are vital support.
Like blood tests.
Definitely. Blood tests are standard. We look for inflammatory markers like CRP, C-reactive protein, and ESR, erythrocyte sedimentation rate. They're usually elevated, showing inflammation, but they can be normal sometimes, especially in oligoarticular JIA.
Okay.
A full blood count, FPC, might show mild normocytic anemia, anemia of chronic disease, and sometimes raised white cell or platelet counts, again reflecting inflammation.
What about the specific markers like ANA and RF?
Exactly. ANA testing is important, mainly because a positive ANA significantly increases the risk of developing uveitis, particularly in oligoarticular JIA. So those kids need more frequent eye checks. RF and HLA-B27 are tested primarily to help classify the subtype, as we discussed, RF for polyarticular, HLA-B27 often for enthesitis related.
Right, for classification and risk stratification. What about imaging? X-rays? Ultrasound?
Imaging plays a role too. X-rays are often done initially, partly to rule out other things like fractures, bone tumors, or infections like osteomyelitis. Early on in JIA, X-rays might actually look completely normal.
So they're not great for early diagnosis of JIA itself?
Not really for diagnosing JIA early, but useful for excluding other causes. Ultrasound is much better for looking at the joint lining, the synovium. It can show fluid in the joint, thickening of the synovium, hypertrophy, and even detect early erosions or damage to the bone surface that wouldn't show on X-ray.
So ultrasound is quite useful then?
Very useful, yes. And MRI gives even more detail. It's excellent for seeing the extent of synovitis, inflammation in the bone marrow, cartilage damage, and soft tissue changes. It's not usually needed routinely, but can be helpful in complex cases or for assessing specific joints like the spine or hips.
Okay. Any other investigation sometimes needed?
Well, if there's any suspicion of septic arthritis, a hot, exquisitely painful joint, maybe with fever, then joint aspiration is essential. You need to take fluid out of the joint with a needle and send it for urgent analysis to look for bacteria.
Crucial to rule out infection.
Absolutely critical. And sometimes, if reactive or post-infectious arthritis is suspected, specific blood tests looking for evidence of recent viral or bacterial infections might be done.
Okay, that makes sense. It's about building a picture using clinical findings and targeted tests. So once the diagnosis of JIA is made, what's the approach to management? What are the goals?
The main goals are, firstly, to control the inflammation and relieve symptoms like pain and stiffness. Secondly, to prevent joint damage and preserve long-term joint function. And ultimately, the aim is to allow the child to have the best possible quality of life, participate in school and activities, and grow normally.
Sounds like a multi-pronged approach.
It really is. It usually involves medications, non-drug therapies, and the input of a whole multidisciplinary team.
Let's break that down. What about prescribing? What medications are used?
Okay, so pharmacologically, often the first step is using nonsteroidal anti-inflammatory drugs, NSAIDs, like ibuprofen or naproxen. These help with pain and some inflammation, but they don't usually stop the underlying disease process on their own.
So they're more for symptom relief.
Mostly, yes. If symptoms persist or the disease is more active, the next step is usually a disease-modifying antichromatic drug, or DMARD. The most common first-line DMARD in JIA is methotrexate. Sulfasalazine is another option, sometimes used particularly in enthesitis-related arthritis.
Methotrexate is common, right? What about steroids?
Corticosteroids have a role, but we try to use them sparingly because of side effects, especially with long-term use in children affecting growth. They're very effective at quickly reducing inflammation, though, so they might be used as intra-articular injections, injecting steroid directly into one or two particularly troublesome joints.
Ah, directly into the joint.
Yes, it's very effective for oligoarthritis, for example.
Yeah?
Or a short course of oral steroids might be used to get a severe flare under control quickly while waiting for DMARDs to work. Steroid eye drops are used for uveitis. If systemic steroids are used, we always monitor closely and often give adjuncts like folic acid with methotrexate or anti-sickness medication.
Are there other DMARDs besides methotrexate and sulfasalazine?
Yes, leflunomide is another conventional DMARD that's sometimes used, but the big advance in recent years has been the development of biologic DMARDs, or biologics.
Biologics, right. How do they work?
These are generally proteins, often antibodies, that target very specific molecules involved in the inflammatory process. For example, TNF-alpha inhibitors like etanercept and adalimumab are commonly used. Others target different pathways like abatacept, tocilizumab, or tufosimetinib, which is a JAK inhibitor.
And when are these used?
They're typically reserved for moderate to severe JIA that hasn't responded well enough to conventional DMARDs like methotrexate, or sometimes earlier in specific subtypes like systemic JIA. NICE guidance in the UK specifies which biologics can be used for which JIA subtypes: polyarticular, enthesitis-related, psoriatic, systemic based on disease activity and previous treatments.
Broadly speaking, yes, although sometimes biologics might be considered earlier in very severe disease.
Okay. What about the non-prescribing side? You mentioned a team approach.
Absolutely vital. The multidisciplinary team, or MDT, is key. This typically includes a pediatric rheumatologist, specialist nurses, physiotherapists, occupational therapists, and often an ophthalmologist for eye screening. What do the physios and OTs do?
Physiotherapists work on maintaining joint range of motion, muscle strength, and overall fitness through tailored exercise programs. Occupational therapists help with adapting daily tasks, things like handwriting, dressing, using cutlery if joint problems are making them difficult. They might also provide splints.
Practical help.
Very practical. Hydrotherapy, exercising in warm water, can also be really beneficial. Regular exercise is encouraged, alongside things like heat packs for stiffness. Sometimes podiatrists get involved too, providing foot orthosis or special insoles if foot pain is an issue.
And addressing the broader impacts.
Yes. The team also monitors for potential long-term issues like growth problems or osteoporosis, which can result from chronic inflammation or steroid use. Psychologists or social workers might also be part of the team to support the child and family with the emotional and social challenges of living with a chronic illness.
It really takes a village, doesn't it?
It really does. Good communication within the team and with the family is essential.
Is surgery ever needed?
It's much less common now with effective medical treatments. But yes, occasionally surgery might be considered for specific problems. If a joint becomes severely damaged and painful despite medical management, joint replacement surgery might eventually be an option, even in young adults who had GIA as children. Synovectomy, removing the inflamed joint lining, is sometimes done, but less frequently now.
Okay. So with all this treatment available, what's the long-term outlook? What's the prognosis for kids with JIA?
It's really variable. It depends heavily on the JIA subtype, how severe it is, how early it's diagnosed, and how well it responds to treatment. But the good news is that with modern treatments, including biologics, the prognosis for many children is much, much better than it used to be.
That's encouraging.
Many children can achieve remission, meaning the disease becomes inactive, sometimes even off medication. Others might have ongoing disease, but with milder symptoms that are well controlled. Having that MDT approach and access to the right medications really does lead to more favorable outcomes overall.
Can we look at the prognosis for the specific subtypes again? You mentioned variations earlier.
Sure, for oligoarticular JIA, while joint outcomes are often good, there's a risk of long-term issues like joint contractures or limb length discrepancy if it's not treated effectively. The big concern is uveitis. If it develops, it can lead to vision impairment in up to 50% of affected eyes, potentially causing cataracts or glaucoma, hence the need for regular eye screening.
Okay, uveitis is the big watch out there. What about polyarticular RF negative?
Polyarticular RF negative has a reasonable chance of remission. Maybe around 25% achieve remission within 10 years, often within the first 5 years.
And RF positive.
Polyarticular RF positive generally has a poorer prognosis regarding joint damage. The 10-year remission rate is lower, maybe around 6%, and there's a higher risk of progressive joint damage and deformities, more like adult RA.
Okay, systemic JIA.
Systemic JIA has a very variable course. About 10% might have just a single episode and then go into complete remission. Maybe 35% have a relapsing remitting course with flares coming and going. But unfortunately, over half, around 55%, tend to develop a more chronic, persistent disease course.
Quite a spread of outcomes there.
It is. For juvenile psoriatic arthritis, follow-up studies suggest around 40% still have active disease 7 years after diagnosis.
And enthesitis related.
In enthesitis-related JIA, if it starts with many joints involved, a polyarticular presentation, that tends to predict more chronic disease. Also, significant hip involvement during childhood unfortunately increases the risk of needing a hip replacement later in life.
So while outcomes are better, there are still significant potential long-term issues and complications to be aware of.
Definitely. Even with good treatment, complications can occur.
What are the main complications we should be aware of? You've mentioned joint damage and uveitis.
Yes, those are key. Joint complications can include deformities like fixed bending contractures or differences in limb length. Bone growth around an inflamed joint can sometimes accelerate initially. Chronic inflammation can lead to narrowing of the joint space on X-ray. In the hands, particularly with RF-positive polyarticular JIA, you can get those classic swan neck or boutonniere deformities of the fingers. Cervical spine involvement can also occur, again, more common in RF-positive disease.
And uveitis.
Uveitis is a major concern because it can be asymptomatic, meaning the eye isn't red or painful, but still cause damage that leads to sight loss. That's why regular screening by an ophthalmologist is absolutely mandatory for at-risk children. It can affect one or both eyes, and its severity doesn't always correlate with joint disease activity.
Silent but dangerous.
Exactly. Then for systemic JIA specifically, there are potentially life-threatening systemic complications like macrophage activation syndrome, MAS, which is a severe, uncontrolled immune activation. Secondary amyloidosis, where abnormal proteins build up in organs, is a rarer long-term complication of chronic inflammation. And systemic JIA can also cause quite destructive joint disease requiring surgery.
MAS sounds serious.
It is. It's a medical emergency. Other general complications can include osteoporosis or weakened bones, partly from inflammation and partly from steroid use. Growth restriction can occur due to chronic inflammation interfering with growth hormones. Then there are potential side effects from the medications themselves. And of course, the condition can impact activity levels, school attendance, and have a significant psychosocial impact, sometimes leading to anxiety, depression, or behavioral issues.
That's a really comprehensive picture. It covers so much, from the basic definition through to the subtypes, management, and those potential long-term complications. It really highlights why JIA needs careful, ongoing management by a dedicated team.
Absolutely. Early diagnosis, tailored treatment based on subtype and severity, regular monitoring, especially for uveitis, and holistic support from the MDT are all crucial for achieving the best possible outcomes.
So, for everyone listening, hopefully this deep dive has demystified JIA somewhat and provided a solid foundation, whether for exams or just for understanding this condition better. The key takeaways really are its chronic inflammatory nature, the importance of early diagnosis and management, the variability across those subtypes, and the need to watch for potential complications.
Well summarized. It's a complex area, but breaking it down helps.
Definitely. It makes you think. Considering how diverse JI is, I wonder, what areas of research do you think hold the most promise for improving outcomes even further in the future? Something perhaps for our listeners to ponder.
That's a great question. Better understanding of triggers, more targeted therapies, maybe even ways to predict who will develop complications.
Lots of potential avenues.
Food for thought.
Mhm.
And for those of you revising for the MSRA or looking for more resources, don't forget to check out pastmsra.com and also freemsra.com. Great resources.
Thank you so much for joining us and taking this deep dive into juvenile idiopathic arthritis today.